So many of you, I suppose, may be familiar with this gentleman. This is Hippocrates. And the reason I suppose he's so important given today's topic is that almost 2,500 years ago, he described what he described as heaviness and convulsions in a pregnant woman. Now, he kind of stated the obvious and he said it wasn't good, which is, I suppose, preaching to the converted. But it took us almost 2,000 more years to actually realise what was happening to these women. So for the 2,000 years after Hippocrates and Plato, there was the general concept that there was 4 humours circulating in the body. There was yellow bile, black bile, phlegm and blood. And that your general health relied on a balance of all these 4 humours. They proposed a lot of different theories about men and women, and that women were the wet version of the species and men were the dry version of the species. And together, I'm not quite sure what they made, but they thought like the yin and yang to balance each other out. And one of my, I suppose, favourite theories that Hippocrates and Plato came up with was the idea of the wandering womb. And that the womb, when it was dissatisfied, would uproot itself from the pelvis, walk around the body and wreak havoc on whatever organ it liked. And this was their way of explaining how you got a lot of different organs involved in things like preeclampsia. And it took, as I said, almost 2,000 years for us to disprove this. Now, whatever they may have contributed to the specialty, they were also responsible for one of the banes of humanity, and particularly of female health, in that they introduced the concept of dieting. And I, for one, would like to get my hands on these individuals for that concept only. They also introduced the idea of purging and bloodletting, either by the use of cups or leeches, in order to try and take some of the volume out of a woman's system. They proposed that pregnancy, lactation and menstruation were the body's natural way of eliminating some of the fluids in the system. And it provided a natural outlet for fluid, thereby aiding the balance of well-being in women in particular. And it wasn't until 1537 that Pope Clement decriminalised anatomy and dissection that we actually got the opportunity to open the female body and see that the womb wasn't this wandering organ, but was thankfully well sited within the pelvis. And it led to a lot of discoveries, particularly in the 100 years thereafter, where you had individuals like Fallopius finding the fallopian tubes, and a lot of the theory on 2 centuries of pathogenesis was disproved. This gentleman here is Boissier de Sauvage, a Frenchman. It took a Frenchman to actually determine that preeclampsia is a condition unique to women. And he produced, of course, 2 or 3 books on women's health, ones like Maladie de Forme, and ones you actually see historic pictures of, particularly on websites now when it comes to discussions like preeclampsia. He produced his theories on preeclampsia in 1739, and it wasn't until 1897 that we actually disproved the association between preeclampsia and epilepsy, and that was the work of Vaquez and Noblecourt. So you can see we haven't actually, for the first, I suppose, over 2,000 years, 2,200 years, we were dealing in theories of supposition. It wasn't until you got down into the actual etiology and pathogenesis of it only in the last 250 years. And this, I suppose, description of eclampsia being different from epilepsy in 1897 came around the same time as the invention of the sphygmomanometer. And so these 2 things, hand in hand, revolutionised our care and our detection of preeclampsia. Interestingly, if you look through the treatments that they proposed historically for seizures in pregnant women, they advised that you used opiates, warm baths, splashing of the face with cold water, and hastening of the delivery. I suppose what's most surprising is that the opiates weren't used in order to suppress any cerebral irritation, but more just to decrease the irritability of the woman when she had preeclampsia. And if all else failed, they would splash the face with cold water or put her into a warm bath, one or the other, depending on which physician you were attending. And thankfully, our treatments have evolved since then. And what we do know about preeclampsia today is that it relies on the juxtaposition of the maternal and fetal circulations. And that's to allow optimal transfer of nutrients between from a mother to her baby. And what happens when this goes wrong? The abnormal development of the placenta in conditions such as preeclampsia seems to be primarily hinging around structures such as the spiral arteries, because they fail to develop into the large capacitance, tortuous vascular channels that you need in order for optimum fetal health. And this then therefore leads to small constricted channels, and the knock-on effect from that is placental hyperperfusion. It also means the structures developing distally pay a price, and you get abnormal trophoblast differentiation in cases of preeclampsia. We know in the normal placenta, the trophoblast, which is, I suppose, our nutrition element within the placenta, you get endothelial invasion. And this is one of those things that isn't orchestrated by just one thing. Louise is probably one of the Irish forerunners looking into the area of preeclampsia. And I know even from her SCOPE trial, there was a proposed 98 different things you could check for to see which one was the greatest predictor of adverse outcome. Most of them are either cytokines, adhesion molecules, extracellular molecules, metalloproteinases, or based on your immunity. I know, I suppose, from the provisional results that she's produced of the SCOPE trial, no one thing in isolation predicts adverse outcome, but it's a fine balance. Like the placenta and the different circulations within it, it's a fine balance of a lot of factors together that give you preeclampsia. As I said, the end point is placental hyperperfusion, and it appears to be both the cause and the consequence of the disease. It's really a case of which came first, the chicken or the egg. Was the placenta abnormal to begin with that gave you the disease, or the disease caused abnormal placentation? And that question really is still out there to be answered. We know there's an immunology basis, and that's because it's more common in first-time mothers, it's more common in women who have a new partner, it's also more common in women with a long interpregnancy interval, and interestingly more common in women where they've used barrier contraception for a long period of time prior to the pregnancy. It's also more common in assisted fertility, particularly in things like ICSI, intracytoplasmic sperm injection. And again, it's proposed because of decreased exposure to the immune elements within sperm and semen itself. There's a proposed link to angiotensin, and increased sensitivity to angiotensin 2 has been described in preeclampsia, as well as a variety of genetic factors. As you've mentioned already, we should be asking women when they're booking in relation to their family history. Traditionally in medicine, you always ask about things like high blood pressure, diabetes, epilepsy, TB, rheumatic fever and jaundice. Those are the 6 things you were told to take in a history. In an obstetric history, I would argue that you should ask about preeclampsia, because women with a family history of preeclampsia have a 2 to 5-fold higher risk of getting the condition themselves. And if you had preeclampsia in your first pregnancy, particularly early onset, there's a more than 7-fold risk you're going to get it in any subsequent pregnancies. Also, a lot of the proteins that are described in association with preeclampsia, such as FLT1 and serum variants of it, are carried on chromosome 13. So there is some genetic linkage there that we've yet to get to the exact background of. There's a different locus at 12q, and it may be linked to particularly the worst or the most severe variants of preeclampsia, where you go on to develop things like HELLP syndrome. And interestingly, this locus at 12q isn't there in the variants of preeclampsia where you don't get HELLP syndrome. But in reality, it probably is a lot of different genetic variations combined with a predisposition or a immunology and an actual inherent tendency towards preeclampsia, the exact nature of which is still out there to be described. And one of the major universities in the States has an empty stand within its foyer waiting for the bust of the person who's going to develop or find out that's the cause of preeclampsia. And that's one of the big 5, that it's waiting there for that person. And it's one of the only, I suppose, that and cancer are one of the only things that we actually are still spending an inordinate amount of time on, and are still trying to figure out as to where and how and why this condition develops. We're getting there, but slowly. Personally, I suppose I would be an advocate that one of the biggest predisposing factors to preeclampsia is systemic endothelial dysfunction, because it explains why chronic disease also predisposes you to preeclampsia, and why preeclampsia predisposes you to chronic disease in later life. So it's part of a continuum of your overall health. And it highlights the fact that everything in your body is within a fine balance between those factors that promote vessel development and those factors that actually work against healthy vessel development. What happens to the cardiovascular system in pregnancy? My remit today was to talk to you on how we go about detecting the 2 cardinal elements of preeclampsia, which are hypertension and proteinuria. And in order to do that, we need to understand, first of all, what happens to the body in pregnancy. You get an expansion of blood plasma volume, and you also get an increase in red cell mass. This is from day 1 when your period is missed. Okay? So when you're pregnant, those 2 weeks from conception until your period is missed, you get a rapid expansion in plasma volume and red cell mass. and it starts pretty much immediately. It does peak, however, at weeks 28 to 34. This slide here from Up to Date just shows you that there's a marked discrepancy between the increase in the plasma volume itself in the blue line and the increase in red cell volume. And it's like, I suppose, for any of you who've got children, it's like my waddy. The more you put in, the more concentrated it's going to be. If you've got a rapid increase in the fluid but not as much in the actual red cells, you do get a kind of a physiological anemia in early pregnancy. And you get a reduction in the hematocrit. You get maximum dilution at about 24 weeks, but by the end of the pregnancy, the blood volume in the pregnant woman at term is about 100 mils per kilogram. Pregnant woman, again, you get a 30 to 50% more blood volume than the non-pregnant women, and as a result of which edema is common. 80% of us will swell during the course of a pregnancy, particularly if, like most of us, where you're on your feet over 6-8 hours a day, you will get some edema, which is gravity dependent. The one caveat I would give you there is that facial edema is not normal because it is not gravity dependent. Edema of the hands and feet, yes, you can expect it, but facial edema is one of those things that should be a clue that there's something evolving rapidly. Your cardiac output will increase 30 to 50% above normal, and half of this rise again will occur by 8 weeks of pregnancy. That's a hell of a lot of changes within the cardiovascular system within a period of 4 to 6 weeks. You also see a huge increase in preload, so work coming back to the heart, blood coming back to the heart, and that's because you've got 50% more blood in your system. And you get a reduction in afterload, and afterload really is the resistance to blood leaving the heart, and that's because the veins in your legs swell. And it also contributes to why you get edema. And your actual heart rate should increase by 15 to 20 beats a minute in pregnancy. The overall result, you get significant changes to pressure, you get a drop in blood pressure in the first trimester. It's part of the reason why you feel so terrible in early pregnancy, is that your pressure has fallen. And it should return to normal, however, by the early third trimester. In reality, it is a fine balance. And what happens when it goes wrong? Whatever the cause of preeclampsia, when it goes wrong, the potential consequences for the mother and the baby are devastating. It damages the placenta, or is the damaged placenta to begin with. Regardless, the consequences are paid by the mother and the baby. For the mother, it isn't just the placenta or the life of her unborn child, it's every system within her body. It's her blood, it's her liver, it's her cardiovascular system, it's her central nervous system, and it's her kidneys. And it isn't just for now, it's for lifelong implications for general health. There are a lot of definitions out there for preeclampsia. The Americans have revised their definitions, and now they're suggesting that proteinuria shouldn't be a key in the diagnosis of preeclampsia, but should really bolster the diagnosis. So it doesn't have to be present for you to actually say this is preeclampsia. In Europe, we tend to concentrate on the Davy-McGillivray definition from 1988, and that is the diastolic in excess of 90 on 2 occasions, ideally 4 hours apart, or diastolic greater than 110 on 1 occasion, and proteinuria. In Irish hospitals, and in the hospital that I work in, we are on the side of caution in that it's preeclampsia until proven otherwise. This next slide is just to show you, these are the symptoms of normal pregnancy. Amenorrhea, nausea, vomiting, and I'm sure if you look at all those symptoms, and particularly I suppose in advance of lunch, I asked you, who's got a headache here today? There'd be a few hands going up. Who's a bit nauseated, who's a bit tired? Again, you get a few hands going up. The reality is, the symptoms of preeclampsia are mixed among this. Okay? If you ask some men, are they tired or headache or nausea, you'll get a yes. And you know it's not preeclampsia, so it's just the general vagueness of the symptoms that sometimes makes it difficult to diagnose. The cardinal symptoms of preeclampsia are headache, nausea and vomiting, epigastric pain, diplopia. I've epigastric pain down there twice, why I don't know, and edema of the hands or feet. I stress the importance of edema of the face is abnormal. The diagnosis of preeclampsia, as I said, it wasn't until 1896, until Rover Ricci developed the sphygmomanometer that we actually could reliably measure blood pressure. It's blood pressure in the presence of the ability to detect proteinuria, which came about with the advance in urinalysis, with symptomatology, and it's very much an opportunistic screen. It's why every woman attending for a routine antenatal visit, whether you think she's low, medium or high risk, should have a blood pressure and urinalysis. And I know, I suppose, as a medic, we're the most guilty in that if somebody comes in without the urinalysis, a little part of you goes, great now, less chance of pee on me today, because trying to do that dipstick, and we used to have little pots in the rotunda with no lid on them, that it is one of those things you have to be vigilant about and insist that if she hasn't got a sample with her, she goes and produces a sample. It is opportunistic, and for some of these women it's detected based on a monthly, a fortnightly or a weekly visit. Particularly the early onset preeclampsia, in our hospitals we say to women when they book in at 14 weeks gestation, GP in 7 weeks, back here in 14 weeks. That is a big gap, particularly if you've got an early onset preeclamptic. And if she's kind of getting the feeling from you that you're not concerned, she's not going to be concerned. So there is, I suppose, a mindset or a school of thought that we should be giving these women early information on preeclampsia so they can empower themselves and know as to what the symptoms are and the importance of the visits. It isn't just a case of we're looking to collect their urine, it's we're looking for the following. Blood pressure is a diagnostic sign, it's an underlying risk factor, and it's an indication of potential morbidity. And as Alison alluded to, unfortunately, treating blood pressure has little effect on some of the potential morbidity that goes with preeclampsia, except for intracerebral hemorrhage. And there is no doubt that your systolic pressures in particular, which traditionally we haven't been that concerned about, are associated with a higher risk of stroke in women. Okay, so it's your systolic that will stroke you. Blood pressure measurement in pregnancy. Some of these slides come from Andrew Shannon, and I'm grateful to him for them because it's highlighting the fact that this isn't a complaint that's unique to the Irish population. Blood pressure measurement in pregnancy, he estimated that they do more than 8 million a year in the United Kingdom alone. I was at a talk recently by Professor Michael Turner, and he was talking about, I suppose, fertility, in that we have the lowest number of obstetricians and gynecologists per capita than any other country in Europe. However, if fertility was an Olympic sport, there would be buses going to Dublin Airport to bring the Irish men home because we have the highest fertility rate of any country in Europe. So we need to match our demand with the actual services available to us. And hopefully this is something that's going to be prioritised in the Irish system in the near future. And this isn't just a case of obstetricians, it's across the board. And it's becoming even more apparent with the numbers of midwives and per patient ratios that have been highlighted recently, in that we are understaffed. And it does mean that we're trying to do more with less. The majority of the readings in blood pressure assessment are taken by midwives, and a lot of the research out there suggests that the person that does the blood pressure the most frequently is the best at doing it. I know from having going through medical school in Galway, I was only assessed once at checking blood pressure, and that was in second year of college. And it was another 4 years before I had to do it clinically. It's one of those things that the more often you do this, the better you get at doing it. There are a lot of errors in blood pressure assessment, both observer errors. If I do the blood pressure, there's no doubt that the next person through will get a completely different blood pressure. We all have our own different techniques at doing blood pressure, and it depends again on what sphygmanometer you use. Is it a manual? Is it an automatic? What stethoscope you use? If you have a cardiac stethoscope, you're going to pick up all the exaggerated cardiac sounds, and it may prove accuracy, but then you have to balance that against the cost of such equipment. It doesn't take fancy equipment to do blood pressure, and that is one of the selling points on it. And again, it depends on who you're measuring it on. Not only her body mass index or what size cuff, but also the fact that if you do a measurement on somebody and repeat the same measurement, you will get a natural increase in the blood pressure. And that's because she's wondering, why are you checking it again? And why are you going again for it? And her heart rate's going to pick up, and it is going to start increasing. And typically that happens after the second or third attempt at doing the same test. A small mention here on cuff sizes. In the Irish population and in the Northern European population, the cuff size of 33 by 15 centimetres is strongly recommended. And that's because our body mass index is increasing. With a small cuff, you get an overestimate. Now, I'd rather you caught more people on the suspicion of blood pressure than outruled blood pressure. So if you work with what you have, but if you, in the ideal circumstances, the large cuff is something that's essential to every antenatal clinic and every ward. Again, this is just showing you what's available out there from a large cuff perspective. There is a drawback, however, with a lot of the blood pressure assessments, not only in how we do it. These are some of the common sources of error in blood pressure assessments if you look through the literature. The first being rapid deflation. If you let the pressures fall too quickly, you may miss. There's a big difference between a diastolic of 96 and a diastolic of 88. One will make you repeat it a period of time later, and one will let you discharge the patient home. There's an auscultatory gap, and there are several schools which suggest that you would actually keep your finger on the pulse and use that as your guide for systolic pressure. Threshold avoidance, have faith in what you do. If it's up the first time that you do a blood pressure, there's a 90% chance it's going to be up the second time. Okay, and go with your gut. You know when looking at the patient in front of you as to, does she look healthy, does she not? Nobody's going to, and I know there is a shortage of beds, but nobody is ever going to get in trouble for admitting somebody because of concerns. The trouble arises where she goes home, gets critically unwell, and either she or the baby has a consequence of that. Interestingly, there's a lot of research out there about digit preference, and we should be recording blood pressure to the closest 2 millimetres of mercury. And that means only 20% of the blood pressures in the chart should end in a 0. But if you look through any Muse chart or antenatal chart, it's all 120 over 80, 110 over 70, 140 over 130 over 60. You get very little kind of 84s, 86s, 88s. And again, the purists out there would argue that you have to measure to the nearest 2 millimetre of mercury. Hands up, I mean, as a clinician, I cannot take blood pressure well. And I do tend to steer myself towards the automated ones, even though most of them I know haven't been validated in pregnancy. And again, it's because we don't do it that often. It's a great sell when you get into the clinic and you find that the blood pressure's been done already. Because it not only saves time, but it means that the person that does it the best has done it. And there are also external factors that can influence the accuracy of our measurements. Movements, arrhythmias, heart valve disease will actually cause an increase in your blood pressure and a difficulty with blood pressure assessment, particularly if you have things like mitral regurgitation or even metal valves. Arterial disease and high pressures and observer errors all lead to inaccurate blood pressure assessments. These are a lot of the automated devices that are out there at the moment, the Omron, the Spacelab, the QuietTrack. And this, I suppose, chart here, while it's a little bit busy, shows you the mean and the standard deviation of the differences in blood pressure measurements between all of these and the measurement that was done by inter-arterial assessment. And I suppose what's interesting is you've got kind of high variations there, both in systolic and diastolic in pre-eclamptic patients of between 11 and 19 millimetres of mercury. That's a big difference. Okay, and why is that? The reality is because only about 2 to 3% of your automated devices are actually being validated in a pregnant population. They refer to the adult, more often than not male. And we have to, I suppose, part of the reason if you get a high reading with an automated device, you should be going for the manual SFIG. This looks at blood pressure as an underlying risk factor. Now, for both pre-eclampsia and growth restriction, if you're hypertensive at booking, you've got about a 1 in 4 chance of developing pre-eclampsia during the course of the pregnancy. You also, if you get pre-eclampsia, you've got double the risk of getting growth restriction in the pregnancy. So it's like one condition leads to another. So it's maternal and fetal health that pay the price and have consequences, even with something as simple as chronic hypertension. There are also a lot of different maternal factors and family history factors that will increase your odds risk of developing preeclampsia in a pregnancy. The highest of which is the multisystem disease antiphospholipid syndrome. But even something as simple as age over 40 doubles your risk of preeclampsia. Your raised body mass index before pregnancy, it's still, even if you've got your body mass index down to normal at the time of pregnancy, the very fact that there's been an issue with body mass previously will more than double your risk of becoming preeclamptic during that pregnancy. And again, it highlights things like multiple pregnancy, other organ diseases such as diabetes, and your family history. This looks at the incidence of preeclampsia according to your systolic blood pressure at booking. And again, as you would expect, those women that are booking with systolics of 121/36, which traditionally in a general medical setting we'd say is fine, have up on a 14% to 18% chance of developing preeclampsia. And the reality is that's because your blood pressure should be low in the first trimester. If you have somebody coming in the door at 11 weeks and their blood pressure is 120/80, it should be about 100/60. And that's because it should fall, and it's part of the reason you feel so terrible in early pregnancy. So a normal blood pressure reading in the non-pregnant women, it should be completely different in the pregnant population. If you're treating blood pressure in pregnancy, I'm going to skip through some of these slides because Alison beautifully illustrated what you should be doing and what arterial pressure you should be looking for. But if you reduce particularly severe hypertension and you catch it early on, you get a 50% reduction in some of the adverse outcomes that have been described, such as abruption and growth restriction and preeclampsia. So early detection and treatment does lead to a reduction in risk, but for those that actually get the condition, you don't get an overall difference in the perinatal mortality. The big thing of preterm birth, whether it be iatrogenic or idiopathic, and there is still a higher instance of small for gestational age infants. So while you might save half of the women from the consequences of developing preeclampsia, those that get it still end up being the severe end of the spectrum. CMAC does recommend that those with blood pressure greater than 160 have immediate treatment, as you'd expect. Some caveats there in relation to those that particularly work in an anaesthetic setting, that anaesthetist should anticipate hypertension if they're going to intubate somebody in a crash section. So those people that are unstable, they have to be stabilised before the delivery, and that's the reason why. If you have somebody who is unstable and they need to be intubated, they will get a reflex hypertension. And while they may not have stroked to the blood pressure before the section, the reflex hypertension does put them at the risk of stroke during the procedure itself. And again, as Alison has mentioned, there are medications you need to avoid, such as sintometrin and nifedipine. New hypertension prior to 32 weeks progresses to preeclampsia at half the time. So while she might be presenting with a blood pressure at 30 weeks and there's no proteinuria, 1 and 2 of those will go on to develop proteinuria. And that's why the Americans are saying proteinuria is not essential for the diagnosis of preeclampsia. They've given some timeframes as to how quickly do we need to treat these people. Mean arterial pressure more than 125, you treat them within 15 minutes. More than 140, you treat them within 5 minutes. And it is the less than 125 that you're looking for. Looking quickly at proteinuria, there is a definite association with increasing and perinatal morbidity and mortality with proteinuria. And it's a shame because of the fact that proteinuria is easy to detect. It's probably one of the cheapest bit of kits in an outpatient clinic is the urinalysis dipsticks. And the gold standard to confirm the screening results is a 24-hour collection. But is that all? There are newer methods of assessing proteinuria that are coming out that hopefully will be a source of investment in the years to come. We know that non-pregnant women should have less than 0.15 grams per litre in 24 hours. It's double that in the pregnant woman, in that she should have less than 0.3 grams per litre in 24 hours. Why is that? And it's because of the fact in pregnancy your glomerular filtration rate increases, there's more blood going through the kidneys, they're more permeable, and you do get an increase in protein in the urine. It also should lead to a small fall in serum creatinine as your physiological proteinuria increases. So while we might be peeing out more protein, we're also getting rid of some of the additional waste elements, such as creatinine. Why is it important in an Irish setting? We always treat it as the cardinal feature of preeclampsia, and it does have maternal and fetal implications. There are several caveats, however. The first is that the severity of proteinuria isn't indicative of the severity of preeclampsia. So just because she's got a +1 on dipstick doesn't mean that, I suppose, her headache isn't as much of a concern. Or frequently, if you see women that are prodromal eclamptics, where they're progressing from being preeclamptic to eclamptic, unusually you see their personality change. They get quite frontal behaviour patterns, they get quite aggressive. And the person that was quite easy to deal with the day before all of a sudden is not making eye contact with you and doesn't communicate that well, which does make it difficult to pick up these women early. And as I said, the Americans are already saying that it shouldn't be a formal diagnostic criteria for preeclampsia. The other caveats are that 10% of women with clinical or histological manifestations of preeclampsia have no proteinuria, and that's why the Americans are stepping away from proteinuria being a cardinal sign. 20% of women with eclampsia don't have significant proteinuria prior to their seizure. They may have afterwards, at which point it's too late. And if it's a multiple pregnancy, there's more protein. So more than one baby, greater risk of preeclampsia, but they're also going to have greater risk of physiological proteinuria because they have more blood volume. Primary and secondary renal disease are also characterised with proteinuria and may first present in pregnancy, and that's because women are more likely to attend the doctor for the first time in pregnancy than before pregnancy. And it's quite difficult sometimes to determine, was this something that happened before, or is it something that we're dealing with now and is unique to the pregnancy itself? And 20 to 25% of women with chronic hypertension and diabetes will also go on to develop superimposed preeclampsia. So you're wondering, is the hypertension the element of her chronic hypertension? Is the proteinuria an element of her pre-existing diabetes? And differentiating between that can be quite difficult. So nothing is as it seems. However, the one thing I would say to you is, if you hear hoofbeats, it's horses, not zebras. Okay, it's preeclampsia until proven otherwise. There's a great, I suppose, mindset in medicine that you're always looking for the label so that you can actually go down that treatment pathway. And I would stress the importance of going with your gut. If you're not happy with somebody in the clinic, they don't go home. Okay. Ideally, the sample for proteinuria assessment should be fresh, should be clean voided, should be midstream, and it should be before a pelvic examination, because you will get increased vaginal discharge after a pelvic examination and a greater chance of a dirty specimen. Urinalysis dipsticks, we know, I suppose, how they're graded, and it's negative, it's trace. Traditionally, we've picked a +1 because there's a correlation between a +1 and 0.3 to 1 gram of proteinuria. Now, you can see what's unacceptable with dipsticks is there's a huge range in the assessment of, or the correlation between the dipstick and the degree of proteinuria. New proteinuria is more than +1 in the dipstick, or 24-hour urine excretion of greater than 0.3 grams per litre in 24 hours. The drawback is, if you have a 70-kilo woman in the clinic and she gets a +1 and she's just been to the bathroom, is that the same as the 40-kilogram woman in the clinic who's been saving up the urine, who's dehydrated and gets a +1? A lot of your +1s rely on the fact that it's 0.3 grams per litre, but not every woman will pee the same amount of urine over the course of 24 hours. So again, it's looking for concentration. When in some of these women, they may tell you it's a morning specimen, but they've just been to the most of us, when you get up in the morning, the last thing on your mind is to produce a specimen of urine for the hospital. That it's when you remember it. And particularly as pregnancy advances, because we're all familiar with the concept of pregnancy brain, where it does take you longer to remember things. And particularly important things, such as getting that urine sample for the clinic. What's the best sample to test? Should it be a random, an early morning, or a timed urine collection? I would nearly, if you had to choose, you'd want a timed urine collection, or an early morning, not the random urine sample that most of us deal with in the clinic setting. There are different moving goalposts, because as I've said already, on different weight women produce different volumes of urine, produce different concentrations of urine, and that will have an impact as to whether she's screen positive or screen negative for proteinuria. And they aren't equivalent tests. The dipstick and the 24-hour collection aren't equivalent tests unless everybody excretes the same volume of urine, which is physiologically impossible. Okay. Why are we using dipsticks then instead of a 24-hour urine collection? We use them because they're cheap, they're available to us at point of care, and they're kind of that first screening test. Even with a sensitivity of 50%, they're a first screening test as to who we should be concerned about and who we can let home. They have a significant false positive and false negative rate compared to laboratory testing. Why are they so inaccurate? Primarily due to the urine concentration or osmolality. They can also get a lot of false positives with proteinuria. So they're telling you that there's proteinuria. In reality, there's not. If there's hematuria there, if there's semen, if it's an alkaline urine, if there's detergents, disinfectants used to clean the perineum prior to urine sample production, if she's on a variety of different medications. Well, in pregnancy, it's less of an issue, particularly in things like radiocontrast agents, because no woman in pregnancy should have a radiocontrast agent in her system. But again, it all depends on the concentration of the urine, first of all, but these can also give you a high false positive. You can also have false negatives if she's got non-albumin proteinuria, if she's got a highly acidic urine or high salt concentration. So somebody on a high salt diet will have a high false negative rate. You will be sending them home when in reality they have significant proteinuria. Despite these limitations, they remain the mainstay of our practice, and that's because that's what's available to us. Who should perform the test? There was a lot of trials out there looking at who does the best test, and that looks at not only if I do the test and you do the test, what it correlates as, but who's best at predicting the overall clinical outcome. And again, it comes down to those people that do it most frequently, and that you follow the instructions on the actual urinalysis dipsticks, because some of them require time in order to determine the evolution of the sample. It isn't just a case of dipping it in and going, yep, that's +1 or that's +2. Some of the additional features on the dipstick do need time in order to get an accurate assessment. False positives and false negative rates decrease with training and or automated equipment. And you have to kind of weigh up the cost of a false negative, which are more of a concern than a false positive result when deciding on clinical threshold. This I suppose, is a visual as to some of the trials out there looking at visuals on dipsticks for urine. The ones you're concerned about there are the red, because they're either your false negatives or your false positives. I would argue that the ones you're concerned about there are the false negatives, okay? In that those women here are the ones that you've just sent home who have significant proteinuria. But either way, they're an unacceptable number on either side of the line. Automated dipstick readers do increase the accuracy, and 24-hour collections are better because they're assessed under strict laboratory criteria for proteinuria assessment. There's the additional benefit that you can yield a glomerular filtration rate if you needed it, and the time of the final urine sample, however, should vary no more than 5 to 10 minutes from when she started the sample. So if somebody starts it at 1 o'clock on one day, it shouldn't be finished any later than 1:10 on the following. It sounds strange, but it's quite strict when you think of it. It's 15 minutes of a window where you've got the potential for an accurate test or an inaccurate test result. Bottle can be kept at normal room temperature for a day or two, and we have done, I know in the Rotunda, I'm not sure what it's like in other hospitals, we have sent people home with the bottles to produce the sample, but it should be kept cool or refrigerated if you're going to keep it for a longer period of time, and that becomes an issue particularly when it comes to weekends. It is considered the gold standard for the diagnosis of proteinuria. However, it's frequently inaccurate, and that's because of that 10-minute window where you have to produce the sample and get an accurate estimation. And interpreting the results of the collection, it's critical to look at the adequacy of the collection by quantifying the 24-hour urine creatinine excretion as well as the protein excretion, because that's based on the muscle mass. And again, that'll try and take into account whether you're dealing with a 40-kilogram woman or a 70-kilogram woman. The 24-hour urine creatinine excretion should be between 15 and 20 milligrams per kilogram, and it should be calculated using your pre-pregnancy weight. So where there's a concern about the accuracy of the test result, look at the weight of the patient, and the lab will actually do this assessment for you. And values substantially above or below this estimate would suggest over or under collection of urine, because there is a very, I suppose, set range of creatinine excretion. What are the disadvantages to 24-hour collection? There's no doubt it's cumbersome, and it's antisocial, even on a ward setting. You've seen women carrying their little bottle around with them. You're not going to be welcome pretty much at any bedside with that bottle. And it's time consuming. It's 24 hours before you get the sample complete, and it's another 24 hours sometimes before you have the result back and you can act on it. Protein creatinine ratios can be performed on a random urine, and they correlate excellently with total protein excretion. However, they're not available in maternity hospitals. Well, they're not available in the hospital that I'm in at the moment. And that delivers up on in excess of 9,000 women a year. So there's something that's quite slowly creeping into practice in a medical setting, but unfortunately not into a maternity setting as yet. They're highly accurate, they are reproducible, and they're convenient when compared to time during collection because they can give you point of testing diagnosis. Unfortunately, in the Rotunda, I'm not sure about Hollis Street, the Coombe, or any of the hospitals around the country, if you're in a general hospital, you probably have a better chance of getting this than in a maternity hospital. They do correlate well with 24-hour urine protein assessment, and midstream clean catch samples are accurate, And there's been 3 systematic reviews looking at them in pregnancy, and they all came to similar conclusions in that they are the best test for proteinuria assessment. The drawback is the kind of grey area between the negatives and the overtly positive test results, and that it's suggesting that women with a protein creatinine ratio between 0.15, below which you're negative for proteinuria, and 0.7 milligrams above which you're positive for proteinuria, should have a correlation with a 24-hour urine collection. But even if we caught the severes, the greater than 0.7 milligrams, and got the chance and the time to treat them, it would make a significant impact on maternal morbidity and mortality. And there were also automated dipstick readers for PCRs. So again, similar to urinalysis, this is equipment that's out there, it's available, and it is the best test for proteinuria, and should be something that if there was any spare cash in any maternity hospital budget that we should be looking at. Because it will knock on into who can go home, and the cost of an overnight stay in our hospital is about €1,100. And that would mean that we'll pay for one of these machines with one overnight stay. This just shows you the accuracy of the different tests, and regardless of what study you look at, you see a much smaller increase or instance of false positives and false negatives when you look at PCR. If you compare it to the traditional visual dipstick there, you have a much smaller percentage of women gone home who potentially are at risk of developing preeclampsia. If you look at the overall sensitivity and specificity, all the trials you would look at would suggest that the visual dipstick has only a sensitivity of about 50%. PCR dipstick, a sensitivity of 94%. So it catches 44 extra women out of 100 who have proteinuria. So it is really the gold standard that we should be striving towards. The future of and it is, I suppose, essentially the future of urinalysis that we should be looking at PCR, protein to creatinine ratio. If I was to leave you, I suppose, at any points, early morning urine or a timed urine, should we be looking at greater than +2 on urinalysis dipstick as being the ones that are most likely to develop a problem? I still think we're looking at +1, and that's because of the poor sensitivity of the test we're using. You check the volume in 24-hour samples in borderline cases, and if the woman is excreting less than 1 litre, either it's a false negative, and it may be a false negative, so it needs to be repeated. So if you have somebody on the ward, it doesn't make a difference if they are 40 kilos or 70 kilos and there's less than a litre of urine in the jar or in the bottle, repeat the test, because it's likely that she's missed out on at least one volume of urine. Okay. Treat proteinuria the same as hypertension, not to wait until hypertension develops, and never to be reluctant to repeat a 24-hour collection in the same patient, because preeclampsia is a condition that evolves. If the mid-arm circumference is greater than 33 centimetres, which for most Irish women is the case, then a large cuff should be used. Again, reiterating what Alison said, nifedipine is never to be used and never to be pierced as we would have done traditionally and placed sublingually. Magnesium sulfate is fantastic, not only for seizure prevention, but now, I suppose, and maternal and fetal medicine, we would give magnesium sulfate to all women delivering less than 32 weeks for fetal well-being, because you get less instance of adverse cranial events in these babies. It's a membrane stabiliser not only for the mother, but for the baby. Run these women dry, and don't be tempted to fluid challenge them just to get a diuresis. They will mobilise that extra volume of fluid that happened early on in pregnancy, but that mobilisation may not be until day 3, day 4, day 5 postnatally. No methyl-dopa postnatally because of the association with depression. And I suppose last and foremost, treat the patient. If you're not comfortable with her going home, don't send her home. Okay, that's the worst of it. Okay.